Yeah, it's so contextual. I thought this was basically the other side of Chicago. I was in interdisciplinary research leader. Curious what's going on in this side. Wonderful in a lot of ways. One of my one thing I really value they really respected me a lot as a I had to be the one who
Are we good? All right. Hi there, everyone. Hi. Well, thank you, everyone, for joining us today. This is a several-part series on the financialization of health. I am delighted to introduce Professor Colleen Grogan, who is the Deborah R. and Edgar D. Janata Professor in the University of Chicago Crown School. She's also the Deputy Dean for Curriculum Development at the Crown School, and one of my co-authors and colleagues. Professor Grogan's work examines the role of private provision and the structure of public entitlements, including the historical evolution of Medicaid policy over time, the role of private sector contracting, the implications of policy changes for Medicaid recipients, and private equity's growing influence in healthcare. She has recently published Grow and Hide, The History of America's Healthcare State, which I believe is a truly remarkable book that documents the growth in public funding of the US health system from 1860 to present day. And in this book, she argues that the public has been intentionally misled about the true role of government. And I think it's fair to say this is really a critical book in this time, and I think will help influence some of the discussion here today. So today's lecture will delve into the financialization of health politics, an area of study that has received very limited attention, but as I said, is more critical than ever. And I'll also add that for our Zoom listeners, if you have any comments, you can put them in the chat. Usually afterwards, we have a pretty long discussion where we try and incorporate some of the questions in that chat. So anyway, I'll leave it there and just say I'm really grateful for Professor Grogan's work in this area and her willingness to discuss her book and the larger topic of the financialization of health politics. So thank you. I'll leave it there.
Thank you so much, Joe, and welcome everybody. It's such a pleasure to be here. I'm hoping, there we go. So I hope for those of you in the room and those of you on Zoom that you were not hoping that I would talk about the book, because I'm actually going to talk more about the financialization of health and health politics of that. That's the project that really emerged out of the book. And in particular, chapter 8 of the book. So if you're interested in this, you could go to that. I'm hoping there will be other events here at Crown and at the Seminary Co-op in February for me, where I will give a book talk. So for those of you that are interested, stay tuned. I do want to talk about the book, but I sort of thought that this would fit better within this financialization of health series. So given that, I'm gonna jump right in. I have a lot to cover, and I want to make sure I finish so that there's enough time for questions and discussion. So I want to start by just acknowledging when I go through this work, I really want to acknowledge my co-authors, and in particular, Joe and Victor Roy, who Victor came a couple weeks ago and gave, I missed it, but I zoomed in for it. Such an amazing talk. And Joe really had this incredible idea to write an article for New England Journal of Medicine, which is in press, right? It was accepted, so that's super exciting. And I just want to really acknowledge Joe and Victor's prominent role in this article. So they kind of brought me along, but they really took the lead on this work. So I'm going to present it, but again, Joe and Victor really took it forward. So super excited about that. And then also want to acknowledge my other co-author, where I'll kind of shift to the financialization of health politics. And for that work, I'm working with Miriam Lageson at Columbia University. And I want to acknowledge the Center for Health Administration Studies has given me some seed grant funding for this work as well. Okay, so in this New England Journal of Medicine article, we're really laying out this framework for thinking about the financialization of health. What is that? So last week, we had kind of one interpretation from our speaker, and I want to offer another one that I think Joe and Victor and I were thinking through. Sort of, it's really that financialization is happening through every kind of level, not just across all the sectors. So we talk a lot, and I think the previous speakers have talked a lot about how private equity has moved into almost kind of every sector of healthcare you can think of. But financialization, we argue, runs deeper than that. So what do I mean by that? So you have these. Is it working? I don't know. Anyway, on the top level, you have the financial actors, and private equity is one of those financial actors, but we want to highlight that it's more than that. And so, you know, we can talk about private equity. I feel like for those of you who missed the previous lectures in this series, I'm gonna. I hope this won't be too cursory, but I didn't want to dig too deeply into all the background information about private equity for those of you who have been here in previous weeks, because we've had a lot of that. But basically, private equity has been the biggest concerns around private equity to date have been the leverage buyouts, right? And so acquiring other companies, and they've been doing that to a really alarming degree. So we have this in the past decade. PE firms have completed, more than 8,000 transactions involving healthcare entities, and that's estimated to be a value of nearly $1 trillion, which just hearing that number is really kind of staggering. They leverage capital. The most concerning thing, I think, as you know, when you think about leverage buyouts, is that they're acquiring companies by taking on an incredible amount of debt, and they're able to exit 5 to 7 years later, and they can leave the debt with the acquired company, right? So they can exit, but the acquired company oftentimes is sort of left to take on that debt, and that's kind of one of the many concerns. So again, I want to move forward to think more beyond private equity, because I think that's one contribution that I think we're trying to make, is that it actually, we have to think about some of the other financial actors. So one are these things called REITs, and I just want to again give a shout out to Joe's work, because he's been writing, doing a lot of work recently on these real estate investment trusts. And so I'm just going to mention it here as a really important additional phenomenon in the financialization of health and kind of financial actors moving into healthcare. But essentially what they do is acquire healthcare properties and lease them to a real estate company and then back to the healthcare facility. So essentially, when they acquire the healthcare facility and they use these writs, they then require that the acquired company has to pay rent for the property. So it's kind of adding on an additional financial burden. There's a lot more to say about that, but again, that's just like another added component that's important to think about. And then there's this kind of indirect ownership. And I think Victor talked a lot about the share buyback phenomenon, which is extremely important. It's sort of, I'll talk more about that in the next level. But when you think about indirect ownership, this is another stage of financial actors. Venture capitalism is part of this picture. Hedge funds have moved into to acquiring healthcare companies and investing heavily in the healthcare space. So again, not just PE, it's lots of other financial actors that are playing a really significant role. So this is just a recent article in the New York Times, and I'm not going to go into this, but there's constantly kind of new financial instruments that are being developed that are almost like hard for those of us who even are studying this phenomenon to stay on top of. So, you know, you have the shadow lending market where they're actually moving heavily into life insurance, which is just sort of, you know, kind of far, some people might think of that far afield from healthcare, but it shows sort of another sort of new kind of loophole. So last week, Aaron Fuse was here and talked about all these loopholes that need to be closed. But it's almost, it's hard when you think about all these new financial instruments that are kind of coming onto the market. It's hard to stay, I would argue, on top of all of these loopholes. And so this is sort of one way to think about this, funding insurance premiums. It's another financial mechanism that that's creating sort of, again, shadow lending in the space. So that's the financial actors. Again, just kind of trying to give you the broad brush overview with a nod to this article that will come out in New England Journal of Medicine. But let's move on to, you know, it's not just that financial actors are moving into the healthcare space. It's also that you have these healthcare entities themselves that are acting like financial actors. And again, Joe has talked a lot about this in his work, but I want to just tell you a little bit, what do we, and Victor talked about it with pharmaceutical companies. But what's really important is that they have all, and when I say they, it's, you know, CVS, Oak Street Health, Optum, United Healthcare, any kind of financial entity, big financial entity you can think of, has an investment arm to their business. And oftentimes it actually becomes such an important, large part of their business that it almost takes over. It becomes almost a bigger part of their business model than what they're actually intended to do in terms of providing healthcare provision. So I think a good example of this is what I've highlighted in yellow, where 164, so I'm sorry, so between 21 and 2022, a number of the largest nonprofit hospitals reported losses in revenue. And there's always a lot of concern when it comes to nonprofit hospitals not doing well, and might they close? I mean, we give them nonprofit status for a reason, right? We hope that they provide a really important community benefit. After all, they're providing hospital care for communities around the country. So when they report a loss, it's concerning, right? But when a researcher looked more closely at what's contributing to the loss in revenue, it wasn't the increase in healthcare expenditures, and they're kind of, you know, providing lots of charity care, for example, which when might think and what many of the hospitals claimed. It turned out to be 164% decline in profit margins due to investment losses. So it was their investment arms that they basically made some risky investments and lost a lot of money on the investment arm. And that's what was really contributing. So again, their investment arms, sometimes they make money, but as investments do, they lose money, and that's putting a lot more risk into the healthcare sector, right? Okay, and then this is the other way in which they behave like financial actors in their own right, is when they engage in this share repurchases, or what's also known as share buybacks. And that's accelerated quite substantially in the last 2 decades. So, nearly 70 billion in profit in just 2022, an increase of 300% in a decade. Are the 7 largest health insurance companies allocated 26 billion in share buybacks last year. So these numbers, I think, just give you a sense of the really large extent to which they're using this mechanism to raise revenue. And again, lots to say about that, but it's just sort of the cumulative effect here that I want you to take away from this. So finally, we have financial actors moving into the space. We have healthcare entities themselves acting like financial actors. And what impact does that have for patients or consumers, individual citizens in the system? How do we think about that? And I think Joe's been really innovative here, thinking about, one way to think about this is the financial sector itself acts as a social determinant of health. So this very mechanism of individuals having to take on a lot of medical debt, also debt in a whole other areas outside of medical debt. So in the paper, we focus more on medical debt to kind of keep it consistent and to address our reviewers' concerns. But what we really wanted to emphasize is that it's not just medical debt, because we have financialization throughout the whole economy in the U.S. Individuals are taking on a lot of financial debt, and instruments are influencing individuals at just in their everyday lives, and arguably, it's really important to think about that as a as financialization is a social determinant of health. And again, I'm saying that, but I really want to attribute that kind of insight to Joe's work. I think it's super important. So on the medical debt side, what we really highlight in the paper is this new phenomenon of medical credit cards, that, instead of financialization resulting in increased innovation and lowering healthcare costs, which they often claim to do, and if you're really lowering healthcare costs, that would ideally lower out-of-pocket spending. It has not done that. If anything, it has. Out-of-pocket spending has increased, not all due to financialization, but I would argue it certainly played a really significant role. We see no evidence of innovation reducing healthcare costs in the US. And so we have, a lot of the arguments for creating healthcare reform back in 2010 were the really high levels of personal bankruptcy due to medical debt. And we're kind of right back to those same levels in 2022. The Kaiser Family Foundation did a really nice, pretty thorough report on medical debt. So if you're interested in that topic, I'd suggest you look there. But our response to that is not, okay, let's rethink the cost curve. Let's rethink the role of financial actors in the system if that's not reducing and if that's not resulting in reduced costs. No, the response is let more innovation into the system and the production of medical credit cards, right? So the response to debt is you can take on a medical debt card and we will help you pay off your loan, help you pay off your debt. Another way in which the financial industry has kind of made its way into the healthcare system. So this is kind of our model of the financialization of health, how it moves through all these different levels within the healthcare system. we also thought a bit about the role of the state in this process. And the role of the state, we argue in that paper, is crucially important. This didn't just happen magically in the private sector. The state has encouraged the financialization process all the way through at each of these levels. It's done it through deregulation of the financial industry, starting most significantly in the 1980s. And again, I don't have time to go through all that, but that's been the state policy to move in that direction around deregulation and helped encourage this whole financialization process among financial actors. It's also, the state has allowed reliable public financing and has created social policy that encourages financialization. So what do I mean by that? So I'll skip over the first. I think we've kind of already talked about that a little bit, but enabling pension funds to invest their funds. So that's another way, besides the federal government allowing deregulation, you also have state governments that have pension funds that are investing those funds in private equity firms, right? The state is implicated at that level in all levels of government, practically. And then, other things as well. Let me move on to reliable public financing. So here, I just want to highlight that so much of the healthcare industry is publicly financed. And this point really does relate to my book, Grow and Hide, where I think that we, even today, continue to be misled into thinking that we have a predominantly private healthcare system. And even though we know there's Medicare and Medicaid funding, we think, and it's true, that the majority of Americans are still under private health insurance plans. We know they're subsidized by government, but those subsidies are constantly hidden. And for people who study this, we know those subsidies are there, but for the general American public, they have no idea the extent to which their private health insurance is subsidized by the government. So just a really significant hiding of the state's role in subsidizing that, but it's not hidden to the financial industry. The financial industry knows when there are public lines of funding, and they particularly are quite interested in those lines of funding that are attached to entitlements or to kind of state-run programs like even the VA, right? So if there's an entitlement, they know if they can find a loophole, for example, in Medicare funding, and again, Aaron talked about this last week, that's a really reliable loophole, right? Because government has to pay. It's under legal statutes to make sure that they pay. The government doesn't go bankrupt, right? So there's quite a amount of leveraging of public funds on the part of financial actors to really, that really encourages them to move into the healthcare system in particular. So just to give an example of that, there was expanded coverage and financing under the ACA. So I don't have good kind of causal data for this, but when you look at the graphs of PE involvement since 2010, part of that was due to the lack of regulations around private investments, and a ton of people have talked about that. But in the healthcare space, there was also this dramatic increase in funding that allowed for profits to be made after the ACA was passed. And this is particularly true around behavioral health care coverage, mental health and substance use, where the coverage for those that for behavioral health really increased substantially after the ACA. And you see this dramatic move from the financial actors into this space. Again, almost all, not all, but a good portion of that funded by public dollars. So Medicare and Medicaid reimbursement provide that that stability that I talked about. And then, just most recently, we've talked about lowering the rates for Medicare Advantage for years now because we overpay the managed care plans, the Medicare Advantage plans. But instead, Congress increased those rates just last year, and that was, again, not lost on financial actors. Private equity is, you have, and I think this came up last week, but United Healthcare, for example, I think I'm getting this right, was it United that decided to actually give up its commercial business and move wholly into the Medicare business. Okay, and so the third reason, or the third factor for how the state is really encouraging financialization in health is just the lack of a cohesive social welfare system. So I think we all know in this audience that the United States has an extremely fragmented and unequal social welfare system. Again, that's not just healthcare across the board. We have an extremely fragmented and unequal social welfare system that contributes to a reliance on credit and high levels of household debt. And so again, as I say, there's lots of examples of this, not just in healthcare, but housing, education. Again, Chloe Thurston's talk earlier this quarter comes to mind, right? So what that creates is kind of this two-sided policy dynamic where the state creates this unequal social welfare system that creates vulnerability and increasing debt. And then the state promotes household reliance on financial markets to access capital in the absence of these social protections. Right. So again, these medical credit cards and other such instruments are encouraged by the state. All right. So this creates, I argue, and this takes me to the financialization of health politics, that there's significant policy feedback effects going on here. So when the state shapes policy that encourages financialization in the healthcare system, the financial actors, healthcare entities themselves who act like financial actors become very activated. And if a lot of their business activity relies on public policy, lack of regulation, a reliable stream of public financing, again, all of the things I just went through in terms of state involvement, then it makes sense that they would become even more invested in influencing health policy, right? And so that, I argue, and I wish I could get this to work, is impacting, okay. So they become activated, and that's created a new health politics, right? So this is kind of the basic logic of a policy feedback effect. And this new health politics then shapes future healthcare policy, right? And if they're really strong, and I'm gonna show you kind of my arguments for why we should be concerned about the strength that I think they have in the health politics arena, they're gonna shape healthcare politics in such a way that they're going to shape health policy that makes us even more reliant on financialization in health, right? And that then filters up to new state policy, which activates even more involvement. So this is the policy feedback effect. So I want to shift gears and talk about the financialization of health politics. Okay, so I argue that there's 6 main factors that describe the financialization of health politics. Ownership, opacity, rhetorical power of positive framing, blame avoidance, lobbying activity that's it is kind of unclear, but largely hidden coalitions, and then again, this all leads to even more, kind of feedback effects. So I'm just going to talk through each of these 6 factors and start with just the extreme level of how, and here I'm focusing, I kind of fall back a bit. I apologize. So I want to kind of revise this work and think more broadly, think beyond PE, but my examples kind of rely on PE. So I think that we do know from, again, so much of the work in PE that part of the big concern is the lack of disclosure, the lack of regulation, that it's really hard for us to understand even basic things about what's happening in that private investment sector, right? And that influences, that lack of transparency influences health politics. So the way in which it influences is I think is explained well by giving you the case of nursing homes. So one of the first moves of private equity into the healthcare space was really around nursing homes. It happened actually quite early on. So in 2000, I think there was the first kind of acquisition by a private equity firm of a nursing home. And once that first acquisition occurred, it spread pretty quickly, so that by 2007, there were hearings in Congress on PE-owned nursing homes, and the hearings were about a number of kind of exposés that had come out, as well as some qualitative studies by some people in the long-term care academics, Charlene Harrington for one, who talked a lot about some significant policy, quality concerns that were coming up around nursing homes. What was happening in in the hearings was kind of this catch-22 problem, right? So there was enough kind of concern that there was a hearing, but there were no quantitative studies. There was very little evidence. And the reason there was very low evidence is that because of the opacity, it's really hard to study private equity and to know which firms are PE backed versus not PE backed. What are all the different ownership structures? It can take a long time just to get the data set together. And so essentially what happened in the hearing was just, a kind of different claims are made, but no kind of like silver gun or silver bullet, I guess is what I'm looking for. So basically, the private equity lobbyists would say, and they continue to say this: there's just bad apples, right? And it's really hard to refute the bad apple claim, right? If you have qualitative data, they can just say, well, yeah, you're pointing to all the bad apples, or if you have an expose that shows up in the New York Times or the Washington Post, again, those are bad apples. They will willingly acknowledge there are bad apples, but they will claim it's not systemic, okay? So so by 2021, we finally get an article, and there are some other articles now as well in other areas, but this was the smoking gun. Sorry, that's the phrase I'm looking for. So Gupta et al., published this study in 2021 saying, that PE-backed nursing homes are associated with higher mortality rates. I mean, a really, really important finding, right? Usually it's hard to associate one behavior to mortality. I mean, it doesn't get much worse than a mortality outcome, right? So that was super concerning, and it did rise to the level of, Congress, of more hearings in 2022. Of course, this was post-COVID as well, when there was lots of concern about what was happening in nursing homes. So it rose to that level, and there have now been new regulations around staffing. So what Gupta et al. Found was that what created that higher mortality was that the typical playbook for PE-acquired nursing homes is to reduce the staff-to-patient ratios, right? So that's what they attributed, and Congress reacted by regulating in that area. But a number of people have argued that that was just way too late, right? So this is just out in the Atlantic, the secrecy industry devouring the US economy. I don't know if any of you saw this, but I recommend it. Basically, they're arguing that private equity has made 1/5 of the market effectively invisible to investors, the media, and regulators. So this is really highlighting the opacity argument that they have some really important statistics. Uh, uh, um, Suggesting that in 2004, I think only 5% of the economy was acquired by PE, but by 2022, or I think it's 22, it's 20% of the US economy. So it's really increased quite drastically, which highlights the title of their article. And then this is just a quote by a law professor who has a new book out, The Problem of 12, worrying also about the financial industry and the lack of disclosure. So basic information about who actually owns the company, how it makes money, or whether it's profitable is just, as he said, disappearing indefinitely into private equity darkness. So the other quote that I have from interviews I've done is, I brought up to somebody who said it's just a bad apple problem, and I mentioned the nursing home study, which provides evidence that it's not just bad apples. It's something systemic. And his response was, well, yeah, that's concerning, but we're done with the nursing homes now. We've moved on to many other things. So I think this concern in the politics sector is that by the time we finally get studies that really do give us good evidence, all this harm has already been done. We've had 20 years of harm in the nursing home industry before we have evidence to prove that there's harm. So it's almost going to continue. It's going to continue to be really, really difficult if we only regulate or don't move towards more transparency laws, unless we have quantitative kind of smoking gun evidence, I don't think we'll move there, right? Because I think it's a circular problem, right? Okay, so the second factor that leads to a kind of unique financialization of health politics is, and I want to highlight that these are all kind of interrelated. That the rhetorical power and positive framing with few challengers is related to the hidden nature of PE, right, and the opacity, right. So this is just some quotes from the lobbying arm of private equity groups, which is the American Investment Council website. And it's not unusual for interest groups to make claims like this, right? So job creation, saving lives. I mean, they're trying to sell their goods, what they're doing. So that's not, we would expect this. But again, what I think makes it difficult is that we don't have, we have more and more challengers in the media with these exposés, but we don't have really great challengers in the political space. And I'll get to more of that later. But their rhetorical power, they have kind of unbalanced rhetorical power here about their claims of what they can do. And most importantly, it's really these, in some ways, I think the power, the rhetorical power, I think I need to change some of these quotes, because I think in the healthcare space, and I'll get to more of this later, where they have the most rhetorical power are arguments around innovation. Okay, and that is particularly persuasive in the healthcare space because they're moving into a really, really, really dysfunctional healthcare system, right? And so nobody would claim that before the financialization of health that we had a good, well-working healthcare system. We didn't, and that adds fuel to the investor claims that we need significant innovation in healthcare. I don't know if I'd call it innovation, but we do need significant reforms in healthcare. And so they would argue it could only get better. How could it possibly get worse, right? And we're infusing all this capital into the system that could only improve. So they have the kind of the better end of the rhetorical power scale. They have it weighted in their direction. Okay, the third is blame avoidance. And this, I think, is really, this again, related to the hidden nature. So, you know, in politics, it matters a lot if citizens are aware of who to blame for a problem, right? And so, if you have an elderly parent in a nursing home and you're really unhappy with the staffing that's going on, or the quality of care your elderly loved one is getting, you tend to blame the nursing home, right? You have no idea there's a financial actor behind that nursing home, that maybe that's where your blame should be directed at, right? And so this, again, this blame avoidance is really, really beneficial to private equity and other financial actors, that nobody knows when the financial actor is behind something they're concerned about, or the degree to which the number of actors that are behind it. Okay. Um, the fourth is lobbying activity is unclear or also hidden. So what I want to pause there and just highlight that the three things I've talked about so far, so on here, these first three, ownership, opacity, rhetorical power, and blame avoidance, those three are really, really effective at keeping the concerns about financialization off the political agenda in the first place. Right? So if you don't know who to blame, you don't even know to say, oh, this is a problem. We need Congress, or we need our state legislature to act. Right? So we don't have a lot of examples, at least in the healthcare space, of really going after private equity. Just in the last year, we have some examples of a movement more on the agency side, like the Federal Trade Commission that Aaron talked about last week. But we don't have, we have some hearings, more hearings again recently, but very few bills that we can look at. Really none. We have no bill. I mean, we have the what is it? Stop Wall Street from Looting Main Street or something by Elizabeth Warren. But that's more general about the problem of private equity in the US economy. It's not focused on healthcare. So it's hard to study the politics of, it's hard to study the financialization of health politics if you don't actually have a whole lot of activity yet going on, right? Which shows you, I would argue, that's even the significant power of financialization, that they're just able to keep it off the agenda almost completely, to date anyway. Again, we have this nursing home example that I want to dig into a bit more. But I'm sorry, the one exception is surprise billing. Okay, so I think probably everyone in this room knows about surprise billing, but just in case, I'll just give you a quick example of what that is, which is basically, and again, I think Aaron talked about it last week, that basically people are going in using an in-network, they think they're using an in-network provider. Even those who have private insurance, actually predominantly among those with private insurance, they even check out that they're going to the right hospital that's in-network. And then after surgery, they get a huge bill. Sometimes, it can be $15,000, $30,000, I'm not talking about $100 copay bill, significant bills. So, which created this term surprise billing, and significant concern that this was just a really egregious practice, that nobody should have to think they're behaving in all the ways that we ask patients to behave, or insurance consumers to behave, and then they're slapped with a really expensive bill. So you had bipartisan support for doing something around this problem of surprise billing. And eventually it came out that private equity firms were behind the surprise billing phenomenon. Okay, so it initially it was a little bit hidden. So I want to get to, okay, so it was hidden because we have kind of this dark money phenomenon of I think it was Patient Unity Group that was doing a lot of ads against surprise billing, that it was going to hurt providers, and nobody knew kind of who was behind the Patient Unity Group because of the dark money phenomenon. Eventually, it did get exposed that it was private equity behind that. So that was an incident when the American public, if you were looking, but it wasn't. Most people, probably are unaware that about even this ad or the dark money. But that was an important revelation. And then there is some data around lobbying. Sorry, but so. But when we did get this No Surprise Billing Act, right, that Aaron talked about last week. And some people have said that's like an example of bipartisanship, an example of us being able to really work against private equity. But I guess I would argue otherwise. And I would argue otherwise for a couple reasons. One is it didn't actually go after private equity. It said, we're going to focus on the out-of-network billing problem, and we're going to limit it so that these out-of-network bills can't be sent directly to patients anymore. So it solved it from the consumer and the patient perspective. I agree with that. And that's super important that people are not slapped with these surprise bills anymore, at least there's other surprise billing happening in our system, but at least in the ER phenomenon. But the way that we dealt with it was through arbitration. Right, so you could so they said what the fight was about: should we create a benchmark price that insurance companies would agree to pay, or should it go to arbitration? Well, the private equity firms really, really wanted arbitration. Okay, and so the debate in the halls of Congress were really about this, and private equity won. They got arbitration, and this has been hugely significant because there are so many appeals to what CMS has been able to come up with. I mean, they got over, I think, 2,000 different appeals that CMS is currently trying to deal with. It doesn't have nearly the bureaucratic capacity to deal with this arbitration process around the No Surprise Billing Act. They're completely overwhelmed, and they're completely outmatched by all the lawyers that are using this appeal and litigation process. So that adds significantly to like the hidden costs of our healthcare system as well, right? Like all this money going into litigation, all the attention being diverted from CMS to this particular arbitration problem. I would not call this bill really favorable to the American public, and I definitely would call this bill what private equity wanted. Right. So the particular firm went bankrupt. What is it? Team Health, I think, or Envision went bankrupt. So you could point to that and say, oh, they went bankrupt, so they're no longer in business. But again, the larger industry got what it wanted out of this bill. Okay. So the fourth problem, as I said, is this active lobbying is hidden. We just don't have good, just as PE is hidden in the healthcare system itself and hidden in our economy, it's also hidden in lobbying. So it's really hard to know, not just through dark money, but just even in our data about lobbying, we don't have good data about when companies are lobbying, but they're PE backed. Right, and so Open Secrets has some data that will signal for you whether private equity is involved in lobbying efforts. And we do see that in at least, this is in the HMO category. They show that PE lobbying on health services and HMO issues has really gone up since 2012. So this is PE affiliated in the top 10. They're the top 50 clients. So we see this increase in lobbying activity in that category. But what's actually quite interesting is we don't see any activity of PE affiliated lobbying in nursing homes or health systems. But we know that PE has moved significantly into nursing homes and health systems and is very active, especially it was active around the nursing home regulations, right? So, so we just know this data is likely wrong. So this is another problem where even trying to study like who's really involved, to what extent is our financial actors active in lobbying, their opacity gives them power here. Okay, talked about this. So the fifth is what I call kind of hidden coalitions. And the main argument here is that and I think this is maybe almost the most important reason for the power of private equity. And it's that it's not just that private equity or financial actors have significant resources and can exert pressure on the political system, on politicians through their own lobbying efforts and through campaign donations. But it's that if we have all these other actors that have also become financialized, that they remember back to that kind of financialization of health, if they are also acting like financial actors, there's no incentive for them to stand up and say, oh, surprise billing is a problem. We're really on board with Congress doing the No Surprise Billing Act. They didn't lobby against the No Surprise Billing Act, but like insurance companies, they were really concerned about benchmark or arbitration, but they were completely silent on private equity's role in that. All of these actors were silent on calling out the financial industry's role in the whole phenomenon of surprise billing. And I think I think it's because there's no incentive on their part to call that out, because they are very much implicated in the advantages of private investment. So we have this real hidden coalition that's happening as well. As the whole system becomes financialized, who are the actors to speak out against this financialization process? Okay, so, and again, I think surprise billing is just another good illustration of this, which is if you look at the hearings, there were so few actors from the groups I just pointed to. There were none that called out private equity. Those who gave testimony only focused on the problem itself and not who was to blame. And then again, the policy design. But you didn't. It just illustrated the lack of actors, what you have to look for is who's not at the table and why are they not at the table, right? And you see that phenomenon I just described in this Surprise Billing Act example. Okay. All right, so finally, this is kind of the 6 main factors, and then we end up with sort of if all these things increase the strength of the financial industry, the financialization, the power of financialization in health politics, then that kind of feedback effect just keeps growing. So you kind of, again, it's cyclical. So we need something to disrupt this cycle. And right now it's hard to see exactly what that will be. All right, so I'd like to spend a little time talking a little bit more about the hidden coalitions. And maybe I'll just end by giving you one example. I have a lot of interview data that I want to share with you, but I spent too much time going through everything else. So I'll just go through one just to give you a flavor of some of the findings. And then I'll stop so we have time for questions. So just, I'm not going to, all the names have been changed to protect respondents' confidentiality. I also don't use their company's name because I worry that it will reveal who I'm talking to. So I'll just start. I think last week, one of the questions that came up from the audience was to Aaron was sort of like, well, why are providers, why are physicians supportive of private equity or supportive of financialization? And it's a complex, I think what she said is there's an age difference, right? Sort of the older physicians who would want to sell are willing to sell to private equity, and sort of the younger physicians want to just work for a larger firm, right? And I think that phenomenon is certainly, other studies have found that that's certainly the case. But I think there's a few other things happening as well, and some of the themes that have come out from the interviews I've done so far are a couple different things that are sort of a hodgepodge here, but it's hard to know exactly what providers are thinking because of these non-disclosure agreements. I just want to put that out there, that sometimes I've talked to providers who are willing to talk to me until they talk to their lawyers and are advised not to. But again, it depends on providers. When we think about physicians, or they're very different maybe from other providers. So I think it's really important, because private equity and financial actors have moved into healthcare across so many different subsectors, that the arguments for why providers might be interested vary a little bit depending on the subsector. So in behavioral health, as I mentioned, there's a major activity in that area. And that's an area that has been very, very dysfunctional for a long time. And I think that argument works throughout the healthcare system, but it really, really works well in behavioral health, particularly in substance use disorder, where it's been run for many years by small mom and pop treatment centers, oftentimes not using evidence-based practices. Oftentimes they're against the use of medical assisted therapy, or medication for opiate use disorder, which has proven over and over again that it's really life-saving. So getting access to methadone or buprenorphine, for example. And so it's not that we don't need capital in that system to really upgrade electronic medical records for the people in substance use disorder, the people running substance use disorder facilities. We need capital for them to have billing systems that work well with Medicaid, because now Medicaid covers those services. So we need capital. But the problem is that when government exited in a significant way from actually providing direct capital expenditures for providers in the healthcare system, it reacted by indirectly subsidizing capital that's offered through the capital markets. And that I think is a huge problem. I think I've kind of suggested that I think that's a problem. And but when they do that, then there's no other option. If you need capital, and I think they do, they kind of have to depend on the capital markets. So part of the argument for provider groups not being against private investment is that they kind of don't. If you really want to make innovations, even if you're, and I think many of them are, if their arguments are very well intended, if their reforms are very well intended, they don't really have another place to go. And so we've created a system to make that happen, right? Okay. So this is Daniel. He was a physician who's now a CEO of a maternity care startup. He talks about building, a maternity solution. He's a person of color, has a lot of experiential knowledge, and working in communities where women of color have really, really high maternal death rates. Again, a really strong reason for creating what he calls a maternity solution. So he created a new startup company and went after capital financing to make that happen. So he received venture capital investment. And when I asked him his opinion about PE acquisition, this is just a quote from him, and I'll stop there because I know I'm taking up too much time. But he said, every stakeholder has a different perspective on what a good outcome looks like. I think for me, there's a desire to build a really successful standalone business. But if you get to a point where private equity thinks you're attractive, for me, I would say that we built a successful business. So he absolutely would be acquired by PE. He would see that as, oh, they would scale up. That means my maternity solution would be embedded in the system. This would all be a good thing. But he's not, he's a smart person. He didn't say anything about, I would be slapped with a lot of debt. They might want to also buy the real estate that any of my clinics or facilities sit on through the Ritz. So it's hard to understand, right? But this is part of what I'm finding is just sort of there's an ethos out there about what is success in relation to capital, to the capital trajectory. And at least, you know, from him, he's like, well, that's how I'm successful. Is I start with venture capital, I keep building, keep doing rounds of investment, and eventually I get bought out, and that means that's a signal of success, right? So he wasn't really concerned about longevity, his own longevity in owning this company. So I don't know what we think about that, but that seems to contribute, right, to providers themselves wanting to engage in this whole financialization process. On the other hand, Nancy, who's a clinical social worker, she doesn't own anything. She's not the CEO of a startup. She was a clinical social worker, part of a takeover process. And you know, the story there is just there was a lot of innovation happening, which is why she was so interested in working for this company that they focused on eating disorders in residential treatment facilities. I won't go through all the quotes, but she just described to me how for 5 years she was able to really do this very innovative practice. They invested really high staff to patient ratios, felt really good about the work she was doing. And then, you know, one day she said we were taken over. And what she described again is it's kind of like another expose story, right? Where it came out of nowhere. The staff had no idea they were going to be acquired, but she said they were given a $10,000 retaining bonus to stay for at least 1 year, which she did because she said, "Hey, I'm a clinical social worker. 10,000 is a lot to me," which is reasonable. But she said over the course of that year, they increased the number of residential units, decreased staff, decreased supervision, and took a lot more high acuity patients. So she said after a year, she couldn't wait to get out of there because she had serious ethical concerns about continuing to work for this company. And eventually they were written up with a number of sort of complaints. But it just shows how she really is somebody who wants innovation, was very excited about innovation, and that innovation came through means other than being taken over. But those stories are kind of getting lost in the shuffle, that capital can come also just from direct ownership, right? And from investments from the bank, which is what initially happened when she went to work with them. They didn't have to be acquired by a private investment firm. So I'll stop there.
For that really exceptional talk. That definitely got me thinking and helped situate all of the other speakers that we've already had and that we'll have in the spring. So do we have any questions? People in the audience or people on Zoom?
Hi, Colleen. I think I missed some critical point, which is how is it that a PE firm can be responsible for any surprise billing? I mean, what's the provider who wasn't in network sends a bill, but how is PE behind that? Or how can PE be behind that?
Yeah, so basically, PE acquired some emergency room doctors management companies. I don't know if I'm getting the name of that exactly right, but it was Envision. And I thought it was two different companies. Joe, I don't know if you remember, wasn't it Team Health and Envision? Were the names of the companies. And basically what these, and I think it was Blackstone who had acquired them, was one of the private investment firms, and so it was what they found was a loophole, and the loophole was always there, but nobody had taken advantage of it, and So there's many reasons you could argue why that might be the case. But what they did, again, it was legal, which is why, so they just realized that, oh, if we can, get a consultant from our ER management company into the emergency room, then we can charge this extra surprise bill, and that's a revenue stream for us. So it was the takeover, the acquisition by a private equity firm that really that catapulted this practice, and it was only practiced, I think, by PE-backed firms. So that's how they were implicated. Sorry about that.
Hi, Professor Grogan. Thank you again for speaking today. I wanted to ask about your concern you pointed out with policy research acting as like a canary in the coal mine kind of situation where we're not going to know until it's too late. Do you have an idea of what a policy solution to that would be? Like, is ownership transparency the answer, or is it that just going to be another thing that then gets another workaround? Like, what is the ultimate stop there if there is an ideal way to do that?
Yeah, that's such a good question. And I think thinking through like what are the solutions is super important. And I appreciated Erin's talk last week where she's sort of like, okay, how do we respond? And I think her response was, let's look for the loopholes and let's close the loopholes. My worry about that is we're always going to be behind the 8 ball, right? Because there are just so many, we have such a fragmented system that those loopholes, we think we've closed all the loopholes and then we haven't, right? And it takes us a while to figure out what the loopholes are, and in the meantime, harm has been done. And there, when I say harms, it may not be a quality harm, but if somebody is using a loophole, which we think is really increasing healthcare expenditures, because the loophole is usually to make a lot of profits, where we might be concerned that there's just bad behavior here, right? Loopholes are called loopholes for a reason, right? Like they're taking advantage of something that we didn't intend to be there. And so, but that, so that to me doesn't, I like as a sort of just, we got to figure out like multiple levels politically to engage, to address problems. And so I like that Erin is thinking about that. I wouldn't in any way want us to stop there, right? So, the other is obviously everybody is talking about we need transparency, but as you said, that would improve the data for sure. I mean, we would then be able to at least study better what are the effects. But even that, if you're, by the time you get the data, and to really have a good causal study, you need to look at least at 5 years worth of data, right? Longitudinal data over time. And so you're just accepting the fact that we're going to let, if we're concerned about behavior, we're going to let that happen. So I think we need to, we have to get more to the root of the problem of what some of these investments are behaving in, right? So one that I would just, that I think really needs to be on the table, and it is not at all, but I think as people worry more about capitalism in the US, and like what are the problems with capitalism, and not just healthcare, but so many areas, one question that I think we would raise is we didn't always have a healthcare system that relied primarily on private, on the capital markets. This is a relatively new phenomenon that emerged, from 1965. Again, policy that was written in 1965 in Medicare. And then the state tax exemption the tax exempt bond has been really influential. But prior to that, government provided the majority of capital financing for the healthcare system. And that worked. Like other governments do provide capital investments for their healthcare systems. We don't have to rely on private capital. If we think that what we're really providing is a public good. Now that's always been contentious in the US, but honestly, I think if you really ask most of the American public, and you wouldn't use that term public good, right? But what is healthcare to you? And should people have a right to healthcare? Should it be free? Should it be available to all? If the answer to that is yes, and should there be more equity? If the answer to that is yes, then you don't have a private good. Because private markets don't react to how they offer products in ways to the public that provide that level of equity, or universal access. So if that's your answer, then I think there's more and more arguments for we should provide the capital investment for public goods and protect them.
I don't know if this is on. You'd mentioned though how we already do finance so many things publicly. I guess aside from, unless like Medicare for all is the only solution then, like that kind of one payer system, while working within the system we have, is there any long-term systemic change that could happen within that?
Yeah, I mean, so we wouldn't, I think here is where like all of us thinking more about comparative health systems and looking towards systems that are not just national health insurance, like Medicare for all is really would be modeled after the Canadian health insurance system, right? And we could look to Germany, which is, organized around sickness funds, which is a lot closer to the system we currently have. We could also think people don't like, I do think there's an argument for thinking about Medicaid for all, like that's super controversial now, but it's, from 65 to present, what program has expanded? Like when we passed Medicare in 1965, we thought that was our stepping stone to national health insurance. And that was logical. That made complete sense that it would be our stepping stone. But but when we look back now in 2023, the stepping stone, the only expansions we've seen is Medicaid expansions in terms of eligibility. Now, Medicare expanded in terms of prescription drugs, right, what it covers, but it hasn't moved beyond those over age 65. So I think if we think creatively, politically, we could think about real mobilization at the grassroots level around the Medicaid program. We just haven't, that hasn't been activated. And if it could be, we could move, I think we would actually have more possibilities for that than for Medicare for all.
So I have a question, but I think it might tie too much to your previous answer. So if it doesn't warrant a distinct answer, that's fine. But it seems like a root issue of, or root cause of some of the issues we see today is due to the government encouragement of financialization. So I'm just going to ask you, why did that happen? Or why does that, like, is that a response to trying to reduce government spending? Or is it like a tacit encouragement? I'm just kind of curious about, why that is.
Yeah, I mean, I think there are lots of books out now on government's encouragement of deregulation of the financial industry. And so I would just point us to some of those books that deal with this much larger question, right? That has impacted health very, very significantly. It's impacted everything in our economy. So I'm going to kind of put a pin in that. But I think, I think one way in which government significantly subsidized the entrance of the capital markets into healthcare was almost by accident, and that happened with in Medicare, the hospital. The American Hospital Association lobbied very, very strongly when it was negotiating over the passage of Medicare, that Medicare would allow within its reimbursement the coverage of depreciation and interest. And so prior to that, the banks were not really interested in providing loans to hospitals because they saw hospitals as a bad risk. But after that was written into legislation that it had depreciation and interest had to be covered under Medicare reimbursement, that calculation of risks shifted completely. And the bank said, well, this is guaranteed. They're definitely going to pay the interest back and pay, it's guaranteed within legislation, Medicare's an entitlement, et cetera, et cetera. So, but I don't think that when those politicians put that into legislation, they just did it as an accommodation to get the hospitals on board so they could pass Medicare, which we make a lot of accommodations to get things that we think are really good, right? I think that was a very big mistake. And then, I mean, this is really drawing more from my book, but when planning legislation failed in the 70s, and there was a shift politically to a broad kind of right conservative shift in the 1980s towards competition and a competitive approach, along with that competitive approach came kind of talking about the importance of the capital markets for healthcare in a really significant way. And hospitals that was really a turn for hospitals to start to care an awful lot about their risk rating in, you know, in the capital markets, almost more than maybe you could argue in terms of quality of care, right? That it impacted the ways in which they thought about taking care of patients, because if they took on a high proportion of patients that were patients of color, their risk rating would go down. If they practiced in communities that were predominantly communities of color, their risk rating would go down. So all this is tied to many other factors of inequity in our system. And that was indirectly encouraged through these reimbursements in Medicare, but also then encouraged through a lot of legislation that encouraged the competitive approach in the 1980s. And the arguments, you know, it's hard to say, right? There were some, I think, legitimate arguments from conservatives who really believed competition was going to improve healthcare in the US. I think it's dramatically failed that experiment. Others would say we never truly got competition, and so the experiment never got tried. But the reason for it never being tried might be because you need strong government enforcement to get a managed competition system to work, and we're not willing to do that either. So this idea of a competitive approach working in healthcare is also hugely problematic, because the people who argue for that also want minimal government, right? And I don't think you can have both to work well. Minimal government and competition working well. That doesn't, I think you need enforcement, and we've had no enforcement.
Just do one last question.
So I have a kind of like a follow-up question about like the surprise bill and PE. So I'm wondering if there's like a reason why the hospitals are letting in the private equity in the first place, and then also, are there any benefits from the hospital's perspectives of letting the PE in?
Yeah, so that's kind of what I'm trying to get at with the interviews that I'm doing. And it's a super important question, right? Like, why are so many actors in the system welcoming of private investors, right? And I think the one answer to your question is that they are financial investors themselves. So some hospitals are acquired by PE, as we've talked about, and Joe's done a great paper on that with colleagues. But they also have their own investment arms. And I think, again, this kind of started them behaving like financial actors and believing that more and more capital creates good in the system. There's a strong belief in that, right? That we can invest more in technology, we can invest more in cost reduction strategies, and all this will improve outcomes in the healthcare system. That's the belief. Now, I don't see any evidence of that really happening from the entrance of capital investments, right? They're just as likely to invest in things which are harmful to the system as things which are beneficial. If the main thing you're concerned about is profit, that I think creates a problem. I'm drifting away from your question, though. Why would they welcome them? The simple answer is, I think, because they themselves benefit as a financial actor. But I think there's others, which again is sort of, the system is already dysfunctional, kind of some of those other ones I had on the slide, right? That's another really strong argument. We need innovation, and it's only the private markets that can provide the capital for that innovation, and they're not wrong. Because again, government exited from the system. So government is also at fault, serious fault here, in my view, because we've created the system in which that's our only avenues right now.
Okay, thank you so much, Professor Grogan, and we really are grateful.